Regarding peritrochanteric fractures, Ivan classification, type 1 is 2-part undisplaced, type 2 is 2-part displaced, type 3 is 3-part lesser trochanter involved, type 4 is 4-part greater trochanter, and type 5 is reverse obliquity. Sign of instability in introchanteric fractures. There are two things which are important for the sign of stability of intertrochanteric fracture. Number one is the size and location of lesser trochanter fragment. Number two is integrity of the lateral femoral cortex. Lesser trochanter comminution indicates comminution of posterior medial cortex, that is calcar. This will collapse into varus and retroversion when loading. Number two, reverse obliquity fractures. Number three, subtrochanteric extensions. Number four, greater trochanter fracture. This leads to medial translation of femoral shaft. MRI study of choice for any occult fracture. Treatment, slide lip hip screw is indicated in all of them except the instability factors. Number one, reverse obliquity fracture. Number two, subtrochanteric fracture. And number three, fracture which disrupts the lateral femoral cortex. Technique, lateral approach to the femur. Risk of perforating branches of profunda femoris artery. Was less reflected anteriorly if bulky. Bleeding from the perforated vessel is possible. Or you can split longitudinally if atropic. Position a guide wire. Lateral view center of the neck. In young patient or hard bone, best to use tap to pre-cut threads. Final screw position 10 mm short of subchondral bone in AP and lateral view. Use of TAD, tip apex distance, very important, less than 25 millimeter. Use short barrel blade only if screw size is less than 80 millimeter. Very important, JBGS 1995 Baumgartner. Reference, increase cutout with increased TAD and low risk of implant failure cutout with tip apex distance less than 25 millimeter. So AP and lateral, if you add together, it should be less than 25 millimeter of TAD. If there is a trochanteric fracture, you can put a trochanteric stabilization plate along with THS to improve it. If bilateral fractures, always start from more stable one. In unstable, 55% failure of DHS. In our setup, we use TFNA. Why we use TFNA is reduced liver arm of the implant. It resists medialization and it's a load sharing device. Regarding arthroplasty, if you're doing arthroplasty, you need calcar replacement prosthesis. Must attempt fixation of greater trochanter to shaft when associated with osteoarthritis. Fix and replace when united. The problems with surgery is screw cutout, number one. Number two, anterior perforation of the femur. Number three, non-union. Number four, the left-sided hip fractures which are unstable has more chance of malreduction due to the rotational torque when putting the screw. Mortality rate 15 to 35%. Delay of surgery more than 48 hours is associated with increased risk of mortality. ASA classification predicts the mortality. To remember something, Z effect is these are the dual lag screw IM nails. When weight bearing, there is a lateral migration of inferior lag screw plus medial migration of superior lag screw. This is called Z effect. when there is lateral migration of inferior screw and medial migration of superior screw. This is called Z effect. Opposite is reverse Z effect. The cause is biomechanical due to imbalance in head and neck compression strength leading to varus collapse. So what should we do? Number one, avoid fracture in varus, severe medial comminution, inappropriate entry point, and poor bone quality.